Well, good afternoon, everybody. I hope that you can hear me, and I hope everybody can see me. For those of you who know me, my name is Louis Kriteman, and I'm a urologist here at Georgia Urology in our Atlanta office, actually the Roswell office and the coming Northside Forsyth office. And today we're going to talk a little bit about aquablation, BPH, and where aquablation should fit in on patients who have, BPH. So if you would be so kind as to keep your phones muted, because if we get too many phones going on that are on, it will cause some feedback, and then people won't be able to hear. And then we'll have a question and answer session towards the end of the talk. So again, I want to thank the Procept folks for helping us get this set up and using technology. Certainly easier doing a webinar like this than it would be to do this, in person. So let's see if we can make this get started. The goal of the presentation is to address the following questions. What is BPH? What are the treatment options for BPH? And then where does aquablation play a role in the treatment algorithm for these patients? When you look at the cartoon here on the right-hand side, you get an idea of what a normal prostate and bladder system should look like. So the bladder is this up here, is a muscle, fills with urine. Urine goes out through the urethra, right through the middle of the prostate. And the prostate is kind of like a donut, and the urethra goes through the middle of the donut hole, allowing urine to come on out of the bladder. As the prostate enlarges, it actually squeezes on the urethra. When it squeezes on the urethra, it causes back pressure into the bladder and makes it much more difficult for the bladder to push urine through. And that's what BPH is called, or benign prostatic hyperplasia. About 1 in 2 men, 50% of men who are age 50 are going to have BPH, and then it increases every decade as we move along. Keep in mind that BPH, or benign prostatic hyperplasia, is not prostate cancer and has nothing to do with prostate cancer. So just because someone has BPH does not mean they're more prone to getting prostate cancer. And just because patients have symptoms of BPH does not mean that they have prostate cancer. And in fact, prostate cancer most of the time doesn't cause any symptoms whatsoever. Also keep in mind that as men get older, this prostate grows larger. Sometimes it impinges more on the urethra than others. So I have plenty of patients who have huge prostates when we examine them, but they actually don't have very many symptoms, and that's because this channel is still open. That prostate grows out as opposed to in, compressing the urethra. And so that's why patients with varying size prostates can have variable symptoms. So just having a big prostate, so if your doctor happens to examine your prostate and say, oh my goodness, your prostate's huge, we need to send you to the urologist, that doesn't necessarily mean that there are going to be symptoms associated with that. So when we look at patients who have BPH, we talk about something called LUTS, or lower urinary tract symptoms. And LUTS is a big umbrella phrase that encompasses lots of different problems. BPH is one of them. If patients have bladder stones, it can cause LUTS. If patients have strictures or scarring in the urethra, they can have LUTS. And quite frankly, women can have LUTS too, because it's really just referring to the lower urinary tract symptoms, which means the bladder and below. We urologists break these symptoms up into 2 categories. The first category here are the symptoms that fall under the ability to hold urine, and we call these the storage symptoms, or also known as the bladder symptoms. And so these are the urgency, the frequency. Nocturia means getting up at night to go to the bathroom, and then having incontinence, having urge that comes on so quickly that you don't have time to go to the bathroom. These are all due to bladder issues. These are all due, in most cases in men, to the bladder having had to work so hard for so long that it no longer can hold urine like it used to hold urine, and you get these types of symptoms. These tend to be the most bothersome types of symptoms that patients have, even though it's not really the cause or the etiology, like we like to say, of the problem. So over here, emptying the bladder, these are what we call the obstructive symptoms. And these are what are directly related to that urethral tube getting squeezed by the prostate. And so these include straining, pushing, and trying to get the urine out or to finish voiding. Dysuria sometimes will happen, which is burning. Hesitancy means when you got to go and you get up there and you have a hard time getting started. You think you have to go a lot and it takes a long time to get things moving. Obviously, the weak stream. If you think of the garden hose that's getting crimped off and the water comes out much more slowly, that's the weak stream that happens when the prostate, wraps around the urethra and constricts the urethra. Intermittency is starting and stopping and starting and stopping. You go a little, you stop, you go a little bit more, again, due to the obstruction. And then retention, meaning you can't get the urine out at all, or you leave a significant amount of the urine left over in the bladder after you go. These are the obstructive symptoms again. And when we do a procedure like an aquablation on the prostate and open that prostate up, these types of symptoms get better first, meaning that you've opened that tube, urine can flow through much more easily, less straining, less hesitancy, stronger stream, better emptying, not stopping and starting. That tends to get better within the first week or two. The bladder symptoms over here are going to take a lot more time to get better because the bladder has to reset, it has to recalibrate so that we can start seeing improvement of those types of symptoms. About 70 to 75% of patients after we open up their prostate will see improvement in these storage symptoms. Sometimes, however, patients' bladders are permanently damaged by having had to work so hard for so long. And some men actually will just have an intrinsically overactive bladder, much like women have overactive bladders and they don't have prostates. So men can get those overactive bladder symptoms as well. And sometimes we need to treat those patients with bladder medication as opposed to with prostate medicine. So obviously there's an impact on quality of life, and the biggest impact that we tend to see in patients is the loss of sleep. So disrupted sleep is the #1 bother symptom that patients see. Limited activities, where patients are always looking for a bathroom. And then sexual dysfunction sometimes can occur when patients have big prostates as well. So when we diagnose BPH, how do we diagnose it? Well, for those of you in my practice, you'll always be filling out these little forms that are asking you about those symptoms that we just looked at. A lot of times we'll want to feel the prostate. Most of the time we're feeling that prostate when we do a digital exam to feel for cancer. We want to make sure we don't feel anything that feels like cancer. But honestly, we're feeling the prostate to get an overall size of the prostate. And we're not very good at diagnosing or having an exact size based on our finger. And the other problem is when we put our finger in the rear end to feel that prostate, we're really unable to feel that amount of prostate that's constricting the urethra. All we're feeling is the backside of the prostate. But doing an exam is an important part of the workup when we're trying to diagnose BPH. Lastly, once we've had a discussion about the symptoms and the patient's filled out the symptom score to give us an idea of what kind of symptoms he has, I will typically get my patients set up for a few tests. And the tests that I will do on those patients will be a special voiding test. It helps me to figure out how hard the bladder is pushing. That's called the Urocuff test. We'll look in the bladder. I will always do a cystoscopy. Remember when we looked at LUTS earlier on, we talked about how other issues can cause LUTS. And so scarring in the urethra, bladder stones, bladder cancer, all of those things can cause LUTS. It's not just BPH. And when I look, I also want to make sure I can see exactly what the anatomy of the prostate looks like. Where is the growth of the prostate into the urethra? Because that will matter in what I recommend to the patient as far as treatment is concerned. And then we'll also do an ultrasound. We want to know exactly how big the prostate is. Remember, the finger doesn't do a great job of assessing size, but an ultrasound of the prostate is a gold standard. And that helps me really figure out what the expectation should be once we do the procedure to open up the prostate. So if you are interested in that score that we talked about and filling that out, and for those of you, again, who are in my practice, you will obviously have filled this out before, and we fill it out every time we do something different or change medications. But you can always go to the aquablation.com website, go to resources, and that'll give you an option to fill out the little symptom questionnaire that we were talking about. So once we have that information, once we've figured out what kind of BPH patients have and how much it's affecting the bladder and the urinary system, then we talk about different types of treatment. We have watchful waiting, which really isn't doing very much other than just following patients. Sort of in between watchful waiting and medications are what I call the phytotherapies. Phytotherapies are things like sal palmetto and other supplements and nutrients that patients take. Medications include the Flomax medications and the generics for Flomax and Uroxetrol, as well as the medicines that shrink the prostate. So there are two different classes of medicines we use. to treat BPH. One are the Flomaxes. Those help to relax the muscles wrapped around the urethra. That opens up the urethra wider when a patient goes to the bathroom. And then the shrinking medicines like the dutasteride or the finasteride, and those will work synergistically with the Flomax types of medications to open that prostate up and shrink that prostate. And then obviously we have surgical procedures here on the right-hand side. Watchful waiting, as I mentioned, for the mild symptoms. The mild to moderate symptoms sometimes will move more from the medications and move to, doing procedures. Medications are never without potential side effects, and we're learning more and more that patients who've been on certain medicines for real long periods of time, that they do have a negative impact. They can certainly impact sexuality and erectile function. There's been some reports also of having some issues with potential mental status or dementia issues with being on some of these classes of medicines for long periods of time. When we talk about different surgeries or treatments, we usually break these down into two types of treatments here, the non-resective procedures and the resective procedures. So non-resective usually means the Urolift type of procedure or the Resume type of procedure, both of which are done in an outpatient setting or an ambulatory care setting. You don't necessarily have to go to sleep for these procedures. We're not removing tissue. In the case of the Urolift, we're actually clipping back tissue using little staples to pull that tissue away from the urethra to try to open up that channel. For the water vapor or the Resume procedure, we're actually injecting steam into the prostate, and then over a period of time, usually several months, that prostate tissue will shrink away from the urethra, again, opening up that channel. There's very low rates of irreversible complications, especially sexual complications from doing these procedures. The question of how long and how durable these procedures are going to be sometimes plays a role, and we tend to have patients who require additional procedures down the road, and they tend to be used for prostates that are smaller than 80 grams. And so that's one of the reasons why we measure the prostate with the ultrasound, is most insurances want us to prove that the prostates are smaller than 80 grams, in which case they'll allow us to do them. For larger prostates, these non-resective procedures don't tend to work very well. We get into the resective procedures. This is where we start talking about the Roto-Rooter job, the TURP, different laser treatments for the procedure like green light laser or whole lap procedures, simple prostatectomy, where we actually will open the rind of the prostate, remove the fruit, and then close that prostate back up again. That's probably the most invasive procedure that we can do, but it's really all we had to offer the patients in the past who had super large prostates, was to operate on them. Nowadays, we can do that robotically. But with a simple prostatectomy, it's still a big operation. It's probably the most invasive thing that we can do to open up that channel. So what are the pluses and minuses? Well, we can do any prostate size with these types of procedures. They tend to have long-term relief, so we're looking at 15 to 20-year durability when we're talking about these procedures if done well, but they have much higher rates of irreversible complications. The erectile function, the ejaculatory function are some things that we talk about. Incontinence can occur in a very small percentage of patients, especially with the older style Roto-Rooter job. So with aquablation, we kind of get a combination of both of those benefits when we looked at the pluses on the last page. Aquablation is a robotic procedure. It removes prostate tissue using basically high intensity water pressure washing. We use room temperature saline or salt water to do the procedure. We're actually resecting tissue, so we're making that channel larger. It's the only procedure that's heat free. So we're not using hot water. We're not using any energy other than the energy of the high pressure water. It's precise, consistent, predictable channel that we'll get every time because the robot is actually doing the procedure. It can be performed on prostates of any size. So I've done prostates as small as 35 grams and as large as 300 grams, and then a very low rate of irreversible complications, very low rate of any sexual complications. So 0% over here, impact on erectile and orgasmic function. 99% of men who had BPH did not have any incontinence after the procedure. And so, in my hands, this has been less than 1% incontinence rate. And so that's very, very important. We're getting no sexual side effects. We're getting no incontinence. We can do prostates of any size. Really, this is the first procedure where we're able to offer all of those advantages. So one of the nice things about when we do the procedure is that it is tailored to that patient's specific prostate. And I'm going to run a little video here in a second. Everybody's prostate is uniquely shaped, uniquely sized. And what we really want to do is make sure that we tailor the procedure to that specific prostate. We don't want to have one size fits all. And that's one of the neat things about this procedure is once I map out the prostate and create that using an ultrasound, which you'll see here in a second, then I press go and basically the robot does the procedure. So let's see what happens when we press this now. So this is going to show, it's a cartoon, so it's not a real person sitting there. But legs up in stirrup for this procedure. I've got my ultrasound view that's going to be over here, and I'm going to have my cystoscopic view over here. So the ultrasound goes in the rear end. It's the same place where I do my ultrasound when I'm measuring the prostate. And then we put the little cystoscopic wand into the urethra, again, very similar to what we did when we looked in the prostate. And then both of those instruments are going to be aligned, and they're going to be locked in place to these little robot arms. You're going to see the hand bringing a robot arm over here to lock that into place. So then we're going to use the ultrasound picture that I have up here, and this is actually a transverse picture of the prostate right here being outlined. And using the computer, I'm going to draw out where I want that prostate to remove the tissue. And it's this little pie-shaped thing right there that is allowing me to draw that out. And so we want to make sure that the water jets don't go outside the prostate capsule. We want to make sure that all of our tissue, the channel we're creating, is within the prostate. And then what we're going to do is tell the computer, once we figure that out, where we want the robot to start the procedure. So we're going to start here. This is prostate. This black over here is urine in the bladder. Where the bladder neck is, where the mid-gland is, where the end of the prostate is. And we're going to move things around and we're going to adjust those numbers so that we know exactly where we want things to go and where we want the robot arm to do the procedure. One of the nice things over here, this little shaded area, is what allows us to preserve the ejaculatory function in patients. And it's a neat way that the robot actually does that. So you can see over here, it's like a windshield wiper going back and forth, and it's going to cut through that prostate tissue. You can see this dotted line is where we've drawn out where we want the pressure washer to do the procedure itself. So we've gone over the hump here of the bladder neck. You can see in slow motion over here what the windshield wiper is doing. And it's going to move through that patient's prostate. Some of the sludge that's going to come on out through this little port here, as you can see that, and most of it is actually going to go back up into the bladder. And we make our way through the prostate. This whole process, once the windshield wiper, once the pressure washing begins, usually takes less than 5 minutes. So regardless of the size of the prostate, once I'm happy with the setup that we've done and we've drawn out the mapping of that prostate, I press go, I keep my foot on the pedal, and it really will be, you know, a 5 minute, 20-second treatment cycle, and we're done. Really remarkable how fast that is, and it's really revolutionized what we have done as far as our prostate treatment is concerned. Take the little catheter on out, or the scope on out of the prostate. I look back in there with a different scope, and I do some spot cautery where I make sure there's no big bleeders right there at the bladder neck area to make sure that that looks fine. Put a catheter in, you're done. My patients will stay overnight after the procedure. And typically we'll go home the next day. So why would one choose an aquablation therapy? Well, as we've said, we have low rates of irreversible complications because we're able to draw this prostate picture out, and it's individualized for every patient that we do the procedure. We're using heat-free water jet technology that's tailored specifically to the patient. We have confidence that since the robot is actually doing the procedure and we've set the parameters that we want the robot to do, we're going to get consistent and predictable tissue removal and then long-term relief. Now, even though we only have 3-4 year data on how long we've been doing aquablation, we know from other extirpative procedures where we remove tissue, whether it's a green light, whether it's a TURP or another type of laser procedure, we know that the procedures tend to last patients anywhere from 15 to 20 years. It really depends on how much testosterone is causing the drive of the growth of the prostate. Genetics will play a role, environmental factors will play a role, but the prostate will grow back over time, but usually it's going to take a long time for that to be the case. So what to expect right after the procedure? After, you know, as with most BPH procedures, you'll wake up with a catheter that allows the urethra to start to heal, and it compresses the bleeders that are on the inside. Typically, patients will stay overnight in the hospital. 95% of our patients will go home the next day. My patients tend to go home with a catheter even after the next day. We tend to leave it in for a couple of days, and that's more from a bleeding standpoint than anything else. So I would disagree with this statement here. Some patients will experience some mild burning during the procedure. But most of the time, there's not a lot of burning when patients have this done, and that's because we're not using any heat energy to burn the tissue. And so it's really just, you know, as I said, room temperature saline that's using to move through the tissue. And so there's very mild postoperative symptoms as far as that's concerned. And typically we'll have patients resume normal activities as far as walking around and all really very quickly, a couple of days after the procedure. I do tend to ask that you don't do any strenuous activity, heavy lifting or heavy activity until you see us back in the office, which is typically 2 weeks. So that's my old picture. We got to get our new picture up there. I do have a new picture. That's my younger brother there from 20 years ago. If you have any questions, we're going to open up I think the lines in just a second, or in the chat room, we can do that. But my phone numbers are on the screen there for either Cumming office or Roswell office. And I'd be happy to see you in the office to sit back and talk about whether or not aquablation makes sense for you as a treatment office, or a treatment procedure rather. It is currently covered by Medicare. That's been a change this summer. Medicare finally came through. We're still waiting on the exact date that they're going to start to pay, but they have said that they're going to cover the procedure. From a private insurer standpoint, the Blue Cross Blue Shield insurances are paying, as well as Humana. And I think once the Medicare folks get everything in a line, we'll see all the other insurances fall into line as far as treatment is concerned. So let me see. That is all the references. Okay, so that is that. And let me see if we can answer some questions that folks had. So there was one question out there that aquablation has been performed on prostates up to 300 cc's. Am I generally willing to perform this procedure on prostates up to that size? The answer is yes, as long as I can see the whole prostate on my ultrasound screen. And so it really generally depends on what the anatomy of the prostate looks like. Once you get prostates that are too large and you can't see them on the screen entirely, it's unsafe to do the procedure. The largest one that I did, I think, was 298, so right at 300. We were able to see the entire prostate, and we were able to do the prostate in several passes. So again, the prostates that are very large, I can't just press go and have it figure out the entire prostate. I have to do it kind of in sections. But yes, not an issue doing prostates that large as long as we can see it. Another question was asked about how the procedure affects PSA levels. Is there any increase of prostate cancer from this procedure? So great questions. The first answer as far as the PSA is concerned is no. This won't have any negative impact on PSA, but it will decrease the PSA because we're removing prostate tissue. And so typically what we like to see in some of our other procedures that we do, Lord knows I've done enough green lights and written lots of papers on green lights and presentations. And typically with a green light extirpative procedure, we see a reduction in the PSA by at least 50%. I would expect, and we really haven't studied it that much with aquablation, but I would expect it to be the same. This will in no way change our ability to follow patients as far as PSA and prostate cancer is concerned. And so once we have our new level set after the procedure, we can kind of go from there as far as PSA is concerned. There's absolutely no increase in prostate cancer from doing this procedure, or quite frankly, any of the other procedures that we do on the prostate. And so even though we get symptom improvement after these procedures, no impact on prostate cancer development. Okay, question, where is this done? In the Roswell office? No, this is done in the hospital. It's done with you asleep. We also tend to do this with a spinal. The only hospital system that I do this in right now is Northside system, and I do them in the Northside Forsyth location in Cumming. And just incidentally, we've done more cases in the Northside Forsyth hospital than any other hospital in the country. So we are the most experienced #1 center in the country as far as aquablation is concerned. Question here, can it be done if we've already had a urolift? If yes, it can be done if the patient's had a urolift, no issue with that. The water just cuts right through the little fishing line that we use for the urolift, and the little clips that are on the urethral side get pushed into the bladder, and then at the end of the case, when we're sucking out all of the slurry and the clots from the bladder, they come out with that. So not an issue from that standpoint. Another question was, is the patient sedated? Typically the patients are sedated, but they also have a spinal in, so they will not feel anything, they will not know anything. Most of the patients, quite frankly, sleep through the procedure. I think we talked about aquablation. The number of procedures we've done is coming in on 100 procedures. Have any of the procedures failed? I guess it would depend on how one defines failure. I will tell you that all of the patients that I've done the procedures on have had improvement of their symptoms. We talked about the little score sheet that we had, and the worst score you could have is a 35. Typically, we usually will see anywhere from a 14 to 18-point improvement in that scoring. So if somebody were to have a 12-point improvement, is that considered a failure? It's difficult to say. I think anytime when patients' symptoms improve, I would not call that a failure. But typically that's what we're seeing with urolift. Can it be done if we've already had a urolift? Yes, we answered that one. Is the surgeon fee covered now under Medicare or covered in the summer of 2021? Are hospital fees and other fees covered? So yes, the surgeon's fees are being covered under Medicare. That's what Medicare has told us. They said, yes, it's covered, but they haven't given us that exact date yet. Right now, we're doing cases on Medicare patients, and Medicare has been sort of, paying the surgeon's fees off and on. We're not really exactly sure what we're going to get, but once they give us the date, we'll know exactly what we're going to get. We're hoping that date might be November 1st. In other Medicare areas around the country, for instance, in New England, they're starting November 1st. The organization's called Palmetto for us that organizes our Medicare payments. We're hoping that they're going to come out with the same ruling. Let's see. Lastly, can this method be used to remove cancer tissue? That's an interesting question, and something that we have not yet really addressed with doing aquablation. Most cancer tissue tends to occur in the periphery of the prostate, in the outer shell of the prostate. If you think of the prostate as an orange, it tends to be in the thick peel is where prostate cancer occurs. And this procedure is working on the fruit of that orange and removing the BPH type of tissue. And so not something that we would tend to use for prostate cancer, but something that's being researched using various different modalities, whether it be high pressure water or different types of lasers or steam therapy. There's lots of research going on about that. But as of right now, no, we're not using that to remove prostate cancer. Let's see, in the beginning of the talk, I mentioned a 75% probability. What was I referring to? So when we talk about obstructive symptoms and we talk about storage symptoms, we find that after we remove the obstruction, 75% of patients will have improvement of their storage symptoms, their bladder symptoms, frequency, urgency, getting up at nighttime, just because we've removed that blockage. And it allows the bladder to relax. It allows the muscles of the bladder to relax so that you have less of those symptoms. The other 25 to 30% of patients where it doesn't improve those symptoms, it's because either the bladder has been permanently damaged due to having to push so hard for so long, or some men will just have an intrinsically overactive bladder, like women have overactive bladders at times as well. And so that's the number we see statistically, a 70 to 75% improvement of those storage symptoms. And the other 25 to 30%, don't get improvement after we remove the obstruction. Okay, good. Those are all good questions. Let's see, is the maximum out-of-pocket cost still $2,600? Yes, right now, from a standpoint of a surgeon's fee, what we had been doing was the patients had been doing an out-of-pocket cost or a payment to us of $2,600. That was for the surgeon's fees. Every single patient that I've operated on, the close to 100 of these that we've done, all of the hospital fees have been paid. So we have not had any issues with the hospitals getting paid. It's just really been the surgeon. And once the patient's procedure is done, then we go to bat for you, and PROCEPT goes to bat for you. meaning that we're going to start the appeals processes with the insurances, trying to recoup some of that cost for you so that eventually we can get some of that money back. I'll tell you that we have been successful fairly well in getting some monies back, but it can be years after the fact. So we've been doing these for a little over 2 years, and even at the 2.5, 3 year mark, we're still finally going through 5, 6, 7 appeals with the insurances and finally getting them to pay some money back for the procedure. So that's going to go away, I think, once the Medicare gives us our final date as to when they'll start paying. Then we won't have to have any out-of-pocket surgeon's fees. So good. So hopefully that's giving you all a good overview of aquablation, a good overview of BPH and why aquablation makes sense in a lot of our patients and why it really is a very interesting new twist on treatment. For those of you who know me, I've been doing BPH treatments and prostate treatments, bladder treatments for over 20 years now. And this is kind of the new kid on the block, but really has a lot of advantages over some of the other procedures that we have, as well as being equally efficacious. And so I really do think it's something worth talking about, and whether or not, the patients are good candidates for this procedure, and whether or not it makes sense in your situation. So if folks are interested in talking more about it, let's go ahead and get you in the office, use the numbers to the office. If you have friends or relatives or anybody else who are interested, this talk that we've done tonight, this informational webinar, is going to be uploaded onto my website. And so anybody will be able to access it thereafter and go through the specifics of what we've had to do. And so with that, I appreciate everybody's attention, and we'll be talking to you and seeing you soon. So thank you very much and have a great afternoon.